Good evening, friends. It is a very momentous situation and momentous day for the portals of IAGES, the Indian Association of Gastrointestinal and Endoscopic Surgeons. The IAGES have been untiringly working on various types of learning modules, basic surgeries, master classes, national collaborations, regional collaborations, various courses. In its ongoing endeavor on bringing the policymakers to be available for our knowledge sharing. We have two eminent personalities today on board with us, Dr. Abhijit Sheth, the President of the National Board of Examinations at New Delhi, the apex body of examinations in various medical specialties of India. With us. And we have none other than Dr. Pavnindra sir. He is the Executive Director of the National Board of Examinations, New Delhi, taking care of all the operational aspects of the National Board. And being a surgeon, I think the body of examination. And I'm, in fact, very happy to introduce to all of you our President, Dr. Raman Goel, who's the President of the IAGES. And he is also an eminent teacher, and where he went on to specialize into a very limited area, and he has set trend that specializing in one area gives more optimal results. And on the other side, he has concentrated on various activities of IAGES, teaching, imparting training, imparting various fellowships, and organizing situational required programs. Especially IAGES was imparting COVID-related issues, and IAGES has published guidelines for various surgical practitioners on minimal invasive surgery and COVID situation. So truly, IAGES have touched upon all the spectrum of important surgical aspects of practice, training, education, and now we are in the most important day of discussing the policy matters of the education. With that few words, let me have the formally introducing Professor Pavnindra sir. Professor Pavnindra sir is the Executive Director, National Board of Examinations. He is the Director Professor, Department of Surgery at the Maulana Azad Medical College and Associated Loknaik Hospital in New Delhi. And he is a very senior and eminent laparoscopic GI oncology and bariatric surgeon. And he is the head of the prestigious clinical skill centers at the Maulana Azad Medical College. And he is the chair of the Division of Renal Access Surgery. And he is the editor-in-chief at Maulana Azad Medical College Journal of Medical Sciences. He is the vice president of the International College of Laparoscopic Surgeons, the president-elect of the Indian Hernia Society, and he is the president of the Associations of Surgeons of India, Delhi chapter. And of course, he has an array of other commitments as well. He is the chairman of the Surgical Instruments Committee, Bureau of Indian Standards. And to add further to his cap, many national and international awards have been bestowed upon him. The most important one, he is the second generation DC Roy National Award winner. A very, very, I would say, a prestigious situation where both father and son getting the recognition in the medical fraternity. And he has also been the proud winner of the Commonwealth Fellowship Award instituted by the UGC as early as 2007. I'm sure there is a long list of achievements for Dr. Pavnindra to be read. I'm sure, sir, we will be benefited on hearing from you. Now I have the honor of introducing the President of the National Board of Examination. Dr. Abhijit Sheth has had his post-graduation in super specialty of cardiothoracic surgery from Sheth KM School of Postgraduate Medicine and Research, Ahmedabad. He extensively has worked as an academician at various medical colleges in Ahmedabad. In 1998, he went to UK for more specialized training in cardiothoracic surgery, where he has worked at multiple institutions in the United Kingdom. To mention, the Freeman Hospital at Newcastle was one of the eminent places. And he went on to get qualified both in the FRCS in general surgery from the Glasgow College, and then he specialized in the cardiothoracic surgery exit exam also. Later, he shifted his training to St. George's Hospital NHS Trust in London, where he had the opportunity to work with one of the most eminent cardiothoracic surgeon, Professor Brendan B. Madden. Dr. Shade has a long and distinguished career in cardiothoracic surgery, cardiothoracic research, and academia in India and then extensively in the UK. He has to his credit more than 20 peer-reviewed publications, 40 abstract presentations, and more than 40 international conference presentations at various world societies. His major research and publications are in the field of large airway intervention, sildenafil therapy for patients with pulmonary hypertension. And then he has spent more than 10 years on learning academics, imparting academics, and researching academics at St. George's Hospital, where he has successfully guided and implemented the training program, both in developing competency on various cardiothoracic segmental areas on endobronchial intervention, pulmonary artery catheterization, and management of patients with secondary pulmonary hypertension. Dr. Shade also has taken his MD research degree from the University of London under supervision of Professor Brendan B. Madden, and he's also a management specialist. He has got his MBA Health Executive from Keele University, Manchester. Again, the list continues. Let me get the ball rolling. Now I hand over the proceedings to our president, Dr. Aman Goval, to set the questions on. Over to you, Dr. Aman.
Thank you, Dr. Kanagwil, for the introductions. And friends, it's a great occasion to have two leaders who are helping decide the national policy on medical education. And more than being the leaders, they are both surgeons, so it's so much easier to understand how they think, how they talk, and what will be the future of medical education, because it's heads of surgeons now. So I think it gives a lot of comfort to us on one side. On the other side, we have a medical education which is at crossroads today because of the sudden change of Medical Council of India into national medical education. And on the other side, the COVID has disrupted the training program for almost a year. So it's with great pleasure that I welcome Professor Shade and Dr. Purnendra Lal, President and Executive Director of the Board, National Board of Examination on IAGES platform, because this gives us an opportunity to reach out to thousands and thousands of surgeons and their children who are studying in different medical colleges and national board hospitals and have issues which they wanted to raise. And as I was mentioning just before this program, I have never seen this kind of excitement about the IAGES program, what I have seen in last 3 days. Because whichever doctor and whichever friend of mine I spoke, he or his wife immediately had questions regarding medical education. So I think that shows the kind of requirement that we are meeting out today. And so taking the first, it's more a conversational issue that to Dr. Shade, the first question is that there has been a lot of consternation or doubts regarding the structure of governance of medical education in our country. This is what I have been experiencing and people have been asking in the last 3 days. So as a person who is leading this and as a person who has extensively stayed in United Kingdom, you are yourself a cardiothoracic surgeon, and since you are in a policy making situation, where do you see the future of medical education generally, say a decade later in our country? Dr. Shade, please.
Please unmute yourself, sir.
You'll have to unmute.
Dr. Shade, you'll have to unmute yourself.
Yeah, thank you so much for inviting me. Now let us take an overview of what is happening around with the medical education in the country. Now, there is so much of criticism has gone in last few years regarding the restructuring of medical education, and medical education has to percolate and advance into the farthest institutions of India, and uniformity is a question diversity as an issue, dichotomy is an issue. Now, having said that all criticism and talking about the problems of medical education, I would say one thing that we haven't gone grossly wrong in our medical education. If you will see the history of decades, India is given the highest talent, even before the IT. It's all the talent which were in the medical field to the whole world. And I think that we should not be ignoring that unless we have our basic medical education is strong, we couldn't have done this so far. So, what is the problem? Problem is not about the talent. The problem is about the uniformity, lack of uniformity, diversity, and dichotomy. For example, in one state, you have let us take, I'll give you an example that the WHO recommends 1:1,000 doctors ratio. Now, it's fine that India doesn't have 1:1,000 ratio, and we need to reach that. Now, important is if you go to the southern states. Now, many of the southern states have 1:1,000 ratio. So, while if you go to the northeastern states and other states, this ratio is grossly missing. So, the one biggest challenge for policymakers in medical education and government and regulating agencies is to integrate system in such a way that we should bring the best out of the medical education. We can reform the medical education in the way that it percolates to the farthest institution of the country, and at the same time, it takes an account of all the complexities in the field of medicine, which has built up over the last 2-3 decades. Let us have a review about it. That, as you said, that there's a lot of doubts or discussions and criticisms. Now, what is happening at the moment? We have two regulating bodies. Now, our body is, by and large, primarily is not regulating body, but we are responsible for postgraduate medical education in India, National Board of Examination, and we form about we contribute about the 1/4 of the postgraduate medical doctors' workforce in India. On the other side, the NMC, which was previously the Medical Council of India, is contributing to 2/3 of the postgraduate medical students' workforce across the India. So that is the one part. Second, we have a two system in the country: the private medical system, public medical system, and both systems have their pros and cons. But we know that in the last 20 years, the corporate healthcare system has advanced tremendously and very strongly. And certainly it has created a very strong foundation and what we call it an opportunities for the coming medical generation to have access to the state-of-art medical technology, equipments, and even to the access to the medical education. Now, where is the problem? Problem is this all institutions, organizations, even the central organizations, until now they were largely worked parallel to each other, and there was no integration between two systems. Now, this is if I compare with the UK system or Western system, in Western system, for the purpose of medical education, the integration of integration of the resources like faculties, like specialist centers, like subspecialty exposure, this all has been integrated so well that it's far better than us for them to get a more structured training in the given specialties like your specialty of gastroenterology and others. So what has happened that this is something which we are discussing about, that we need to integrate the system in the best possible way, where we utilize each of our strengths, not the weaknesses. And every institution strength each other, and we utilize and we invest into that in such a way that our medical doctors are at the greatest advantage by getting the opportunities for the best possible training. So that is the one important issue is an integration. The second important issue is the regulation. Now, this is very important. I used to learn a lot of management things before. That if we are not regulating ourselves or our organizations, our institutions, and if we go very linearly and loosely, then certainly the what you call it the basic work culture or the discipline amongst the institutions are not going to come up to that level. So this is the second most important is possibly the regulating bodies has to be little bit stronger and more objective on the principle to ensure that the medical education reaches to the level of expectations. Now, irrespective of whether it's a DNB, whether it is MD or whether it's MS. The third important point is, as everyone has a concern, that there is a lot of cables and this. When you turn from the one system to the another system, when the changes happens, there is always a chance of little bit of chaos around, because people doesn't know what the new system will bring in, what the new system will have an initiative. So by the time they get ready, there is always a concern and there is always a doubts about it. But I am confident that the objectives which was built up in the new policy reforms, with whatever it is NMC or National Board of Examination, I think there are more focus on achieving the excellence in the medical education. Now, it may look little bit disorganized at this stage, but I promise you that in coming 5 or 10 years, we will get far above the expectations in the sense that we will be much better organized. We will have access, all of our regional institutions will get better. The access of the medical education will get better. And certainly all these complexities will be built in. The last point which I would tell you is the conventional system of medical education is a physical education. Now, we all learned from the COVID time that the physical education is grossly missed in the year 2020. And that has led to possibly fast-track innovations in the online learning system, e-learning platforms and all these things. I always picked up the principle in this way, that we should have 3 arms in the education system. The one is physical. You cannot replace the physical education. It has to be there. And that is the gold standard on which we could send so many doctors across the world. So physical education is the one most important pillar which has to stay on. The second important pillar is skill-based education, which is very, very important when the technology has advanced into the medical education. A lot of subspecialties have been built. Even in your gastroenterology, a lot of subspecialties has been built. So second is a skill-based education, which needs to be built in. And the third important thing is a standardization of education. The standardization of education and the effective use of the resources, faculty resources. You can do it with the online portal or e-learning portal, even to the extent that you can had gotten access to the global leaders to contribute to the medical educations in India. So this is my my thought about it. So in conclusion, I will say that please give some time for these reforms to get implemented, and we should not be concluding it too early and too quickly. That is number one. Number two, we must have a physical, digital mode of education where physical, skill-based, and digital, all three should complement each other. That cannot replace with each other. And third important piece, we must build up very strong research and academic capabilities like publication capabilities and others. For that, we need to build up three virtues. One is if someone is able to criticize, someone is able to debate, someone is able to argue. These are the inherent characteristics of academics, which we should take it positively, and that will certainly help to improve our systems. And I welcome all this criticism from my colleagues. Thank you.
Thank you, Dr. Seth. I think that was a very detailed explanation of how things are going. Though it's a little concerning that we need to wait for 5 to 10 years for things to clear up. But I think as the leadership has taken charge and all of you are well aware of the problems on ground, you understand that those postgraduates who are going through this training or the transition phase are not getting adequately trained either, or they are going through a situation where they don't know how well they are trained. But I'm sure once the COVID things is over, things should be brighter in future. Taking a point to Dr. Pavninder Lal, and Dr. Pavninder Lal happens to be the executive committee member of IAGES, so he's a colleague who works with us on a regular basis as well. Dr. Lal, Dr. Sheikh mentioned about the standardization. I think one of the major challenges that students face. So one thing is when you sit in the national level, you are looking at the number of doctors in different regions and you see diversity. My concern is diversity in training. So if a surgeon gets to do, let's say, 10 appendix during his first 6-month post, the other surgeon gets maybe no appendix or one appendix, either because they are in different regions or different medical institutions for training, or there is an element of favoritism. Since both of you are trained in UK, where there is a standardized protocol that the person must do so many procedures before he moves on to the next level of training. What is being done to standardize medical education in India? Yeah. Dr. Pavninder.
Thank you very much, sir. Thank you for this invitation on the prime time of IAGES. It's a great honor to be here. As Dr. Sheikh mentioned, we at the National Board are very actively engaging now with the stakeholders, both the hospital side, the people who are giving the training, and the students who are the people who are going to benefit from the training. And one of the things that we have moved on to is very active participation of the National Board with the specialist boards. One of the unique features of the National Board is that we have a specialist board for every subject, and that is contained of top leadership, both from the academics and from the practicing hospitals, of the best talents and intellectuals who can come together and guide us on the way the curriculum or training needs to be changed or modified. So that's in the last few years, the National Board has been engaging very actively in these specialist boards and making sure that we are getting a constant feedback on the training aspects of the various subjects and the various trainees. One of the new reforms that has been rolled out now and which should become implemented from the current year would be an e-logbook for every student, and it would be app-based, because most of the students are now having smartphones. So we would be launching it on the smartphone of for every student, and it would be having a faculty component, and the faculty or the guide or the supervisor would be having the other component of the logbook. And all these softwares will be integrated in such a manner that when the cases are entered, they will also be entered into the database of the national board itself. So there will be a lot of ease with which we will be able to record cases and document what kind of training that is happening. And this will be going and meeting one of the targets that you said, that if there is a lopsided training, we will have opportunity to get back to the trainers and engage with them to make sure that the training is of a certain standard. Also, another new thing that has been instituted at the national board is an yearly annual review process. And this annual review process really means that once the accreditation is granted to an institution for a particular subject and a particular course, and they normally would be relooked at 3 years or 5 years when that accreditation finishes. Now we would be engaging with them on an annual year basis, where we will see what kind of numbers have been performed in that 1 year, what is the faculty position. Faculty position should not have reduced during the current year, and so on. And therefore, all these measures would go a long way in ensuring that a standardized training continues. And the third initiative that we have taken in the COVID situation and seizing it and making it to an opportunity was to start as a teaching role, which the national board had not previously had so actively. We have now started webinars on a regular basis. I'm very pleased to say that 25 subjects have already started. We have allotted 1 hour to every subject, and we have taken a very huge license which can reach up to 5,000 students. And you know that is a maximum that you can have. You don't have any number more than that required. And we are giving 1 hour to every specialty. So for example, it is for your subject, for our subject here, minimal access surgery. Then 1 hour will be for that minimal access surgery. It could be for case presentation. It could be for CME lecture, journal club, seminar, case discussions, panel, symposia, or anything like that. So these are also newer initiatives, and I'm sure that other subjects which which have not yet started would also actively start. And so we thought that at least one certain level of training for the first year, second year, third years would be imparted, and there would not be an immediate rush for the students to attend CMEs and workshops. Some standard training would be reaching to them wherever they are. And I think all these initiatives will go a long way in fulfilling the standardization required, as you said. And lastly, we are very close to starting a national level, very, very high quality skills center, and that would become the the epitome of excellence for the entire country, where to begin with it would be at one place, and then maybe once the whole process is successfully rolled out, it could be replicated. And the skills are something that are very, very important. The government of India has been supporting and promoting skills, and all of us in medical schools and all of us in associations have also been targeting skill development. It is actually that is the end result of everything. They should be skilled surgeons or skilled physicians, and whatever are the skills that are required for that particular specialty, we would be able to teach them, and these would be both in surgical specialties and non-surgical specialties.
and this would go a long way in improving the standards of the students in their respective subjects.
Yeah, wonderful. So I think that partly answers the question, because the standardization is the ongoing process, and you are making some beginning there. Dr. Kanagvel, you are getting all the questions. So many questions are flowing in.
Yes.
Please go ahead.
Sir, I would like to take the next question to Dr. Abhijit, sir. The Government of India, from the Health Ministry aspect, health provisioning and health education are two eyes of the health industry. The health services availability are contributed both by the government structure as well as by the corporate structure and standalone practitioner structure. So how the board or how the National Medical Commission is planning to utilize the educational infrastructure? I would say, I won't tell educational availability of clinical material. Many corporate hospitals are coming up. Many district level hospitals, taluka level hospitals have enormous clinical material. How the board or the National Medical Commission is having a vision to utilize this clinical material for benefiting the students to learn from this clinical materials? Sir, please unmute yourself, sir.
Yes, sir. This is exactly what I discussed initially. Is the one of the biggest challenge with the NMC, National Board of Examination, and the healthcare infrastructure under the Government of India, both public and private sector, and the independent practitioners. I think the most important aspect is we need to find the way to integrate ourselves in such a way that not a single resourceful bed remains unutilized for the education, number one. Not a single talented faculties should remain unutilized for the training purpose, and not a single foundation which has all the capabilities to train the students should remain unutilized. I think the integration talks about bringing the resources together to the best of the benefit of the students. I will give you an example. In National Board, many times we discuss this example. I'll give you one branch is OBS and Gynae. Now, what happens that in the government institutions, you have a very strong obstetric department, but your gynec department is normally average, by and large. No? So that some place you may find very specialist center, but by and large. The second important, so on other side, if you go to the corporate sector has a far more structured the gynec department than the obstetric department. So simply, if we integrate these resources in a way that students have a compulsory rotation sort of system, or students have access to the either of the organization for the purpose of training of both obstetrics and gynecology, then your purpose will be solved. This is just an example I am putting. This is exactly what we need to do with whatever the resources we have it in the country. There are huge resources which has gone unutilized. And rightly, the NMC as well as the National Board Examination both have started focusing on it, like district hospitals across the country, like the major government hospitals across the country. NB has got very strong foundation with the private organization, but NB has now extended its scope beyond 200 bedded institutions, and now we are reaching to almost 100 bed institutions, and we are reaching to even lesser than that numbers in some of the subspecialties. So what we are trying to encourage more and more institutions to come and participate into the postgraduate medical training program. Now, this is what the national board is doing. What the NMC is going to do is NMC is certainly going to strengthen all the possible district hospitals across the country to turn into a very active education center. And certainly the next step will be integrating these institutes and even to the private institutes in such a way that the access to the education to all students are there. I'll give you an example that we have already taken a decision with previous board of governors and the National Board of Examination that where the government institutions are not running the MDMS courses or fellowship courses, they should be allowed to run these courses into the public sector organizations. And now a lot of public sector organizations have started DNB program, and a lot of public sectors organizations started even to the FNB program. They are going to start the FNB program. To the extent, we have also now convinced, and the NMC has also been very cooperative to the extent that even after the MD and MS, if there is a possibility of subspecialty development in particular area of the public sector, then they can start FNB there. There is no provision of fellowship programs in the NMC. So it's basically not like a recognized, but it's mainly for the training, skill training of already the postgraduate doctors. So it's like more like a postdoctoral degrees. And many public sector organizations have also agreed to participate into this FNB program. So this sort of integration is certainly going to help us a lot. The second, which NMC is possibly going to take, I still don't have much access to the latest NMC newer guidelines, but I understand that they are also going to utilize the more and more faculties possible into the public sector organization for the purpose of training. And this is what, even to the extent that they will be treated as a visiting doctors or sort of an adjunct faculties, but they will be utilized for the training. So let us conclude in this way. First, we need faculties to train the students. So for that, we need to pull much more number of faculties into the pool. Both National Board of Examination is doing it, as well as the NMC is also doing it. So that is number one. Number two is how we give an access to the students to the base centers. So NB has already started external rotation program, and it is working well on particularly in certain institution and certain area. Possibly, I feel that in the coming year, it will get more formalized clinical rotations, and certainly it will get much more useful for the students to rotate into the Institute of Excellence. So that is the number two. This is from the NBSFN. From NMC, we are awaiting the further reforms into this area. The third important is now there is we are exploring the possibility of rotating the private sector students to the government institutions for clinical rotations, as well as the government is also going to sponsor their doctors to the private institution to train themselves into a different specialties and subspecialties, so that that's why I'm telling that there are so many reforms that if I will say that it will be everything will be done overnight and tomorrow will be great day, that's completely wrong. But over the time, I am seeing the very positive changes with all these things, and this has been done with a lot of open mind. So I'm sure that these all sorts of integration changes are going to happen. That is the second. Third, the importance is if you make the institution as an educational hub, the state governments will also be motivated to put the more clinical resources into that institutions. And this is how the district hospitals we are expected to reform by starting this institution as a medical hub. So these are the main changes which we are expecting. And lastly is about the research and education. Again, I am telling that digital platform, which is widely accepted, and we must utilize this platform to ensure that every student has access to the great faculties across the country. And that's what National Board has done. And I'm sure the NMC will also do. Thank you.
Thank you, sir. Raman, sir.
Thank you, Dr. Sheth. So I think you have mentioned so many reforms, they are mind-boggling, and I don't know how they will be ultimately implemented. And definitely they will be implemented, I'm sure. But Dr. Lal, I have heard you earlier, we have discussed it also, and Dr. Sheth has mentioned twice about using district hospitals as a training center for postgraduates. Can you elaborate on that? Because this is the typical British model where postgraduates are posted in every hospital, and they are working day and night. They are the backbone of NHS as they are doing their training, and they are also providing service. So what is on the cards?
So I'm very pleased. Thank you, sir, for this question. This, as you have rightly picked up, district hospitals are the place where about 60-70% of our population is attending the hospitals. And the government of India was concerned about how care could be extended to these hospitals, because even 75 years after independence, for whatever reasons, we have not been able to bring the resident scheme to the district hospitals. One, there are challenges because the hospitals are in peripheries, they're in the interiors. The infrastructure of these hospitals is pretty limited. The faculty strength of the hospitals are also quite variable. They're not constant at all the times. But the patient load is always very, very heavy. And one of the learning experiences was the COVID scenario itself, where the government found that the lack of resident presence in the peripheries, in the district hospitals, made it to close, big, large tertiary care hospitals in the main cities. It was the other way around. Whereas for something as basic as needing oxygen, which could have been done at any hospital, and provision of basic life support services, nothing major surgery was required, not even major ventilation is the treatment for this condition. We were found wanting as far as our peripheral care was concerned. So with these two things in mind, two very big changes have been introduced in this year. And I'm very pleased to say, as far as the government is concerned, they gave us the mandate in the national board to start diploma programs in these district hospitals. Just for the information of everyone, the diploma programs were discontinued or converted to the degree courses as far as the erstwhile MCI was concerned, because the 2-year diploma programs do not result into a medical teacher. Medical teachers need to be a full degree holder. So the government found that there was no use having diplomas from medical colleges. Add one more year and let them convert into a degree, so that at least the people coming out can be taken as teachers in the new medical colleges. And there is a great shortage of teachers, as you know. So over a period of time, the diploma courses vanished or just disappeared from the scene, and the diploma space became available. And the government then mandated and wanted the national board to look at this possibility of starting diploma programs in the district hospitals. And so as a very major initiative in this current year of COVID, we have launched 8 diploma courses in broad specialties which are present in the district hospital, namely anesthesia, gynae, pediatrics, family medicine, ophthalmology, ENT, medical radio diagnosis, and tuberculosis and chest diseases. So in these 8 specialties, we have already started diplomas, courses. We've announced diplomas, and we have also provided, now National Board is very, strategically placed to provide a career pathway for these people who do a diploma. We at the National Board have 2 types of DNB. One is the 3-year DNB, which is equivalent to the MS or MD, and one is a 2-year DNB, which is referred to as a secondary DNB. And the secondary DNB entry is from the diploma courses. So these diploma candidates can do the career progression by going for upgrading their diploma to a full degree by doing a 2-year secondary DNB program. So they have a career pathway in front of them. And the government also mandated for these 50% of the seats in the district hospitals to be reserved for in-service doctors. That would encourage a lot of MBBS level doctors to get upgraded to a better, slightly better specialist position and give their best as far as they could for the welfare of the people. So this was one major initiative that we have launched. I'm very pleased to say that we are at the present moment evaluating 1,000 plus of these applications, and if all is well, about 1,500 to 2,000 seats in the diploma category can be added in the new year 2021 through the NEET PG exam. And the second landmark initiative which the Government of India has done through the National Medical Commission now and the erstwhile MCI is to have a compulsory rotation of every postgraduate in the district for 3 months period out of their 3 years period. And this will be done in their latter part of the post-graduation. That means in the 2nd and 3rd year, not in the first and 1.5 year, because they are doing their thesis at that time. So every postgraduate, every subject from anatomy to whatever other clinical subject is, will be rotating through this through a district hospital designated for that particular medical college. And this scheme is known as the district residency scheme. It has been gazetted. It will be effective from 21 onwards. And both of these initiatives, I think, would answer the concerns that you raised, Dr. Goel, about the care and enhancement of care for our people attending the district hospitals.
Dr. Lal, I think that's wonderful. I have just 2 follow-up questions to you, because you made a very significant announcement or shared the information. One is that those who are doing diploma for 2 years, you said they can come and do a degree. So will that degree be 1 year or 2 years?
Yeah, so that is a post-diploma secondary DNB, which is a 2-year DNB, sir. And therefore, they have technically done 4 years in that subject, 2 years in the form of a diploma and 2 years in the form of a secondary DNB. And in that 2 years, they do their thesis and they do their final year. So, and these are usually at the same centers where the 3-year program is going on. And obviously, they're at good hospitals with a lot of workload, with experienced faculty, so that they are able to train both of these. And the training for both these categories in that hospital is similar. There is no difference between the residency, because they are equal residents. One is getting exited in 2 years and the other would exit in 3 years. In fact, the person who is coming as a diploma is slightly better off, because they've already spent 2 years in that specialty doing the diploma. So they get a little bit of a better quality help when they get a secondary DNB candidate. And when we do accreditation for various institutions and give them seats, we give them seats for both categories, both for 3-year and 2-year course. So there are enough number of seats, but these are to be filled only by the people who have diploma holders. And there is a separate entrance examination for this purpose conducted by the National Board.
Okay, so one more question about the same thing. Skepticism is always there. It's so difficult to regulate medical colleges and corporate hospitals. Does the does your board have the resources to monitor these district hospitals? Because they are a different ball game altogether.
Very important question, sir. And this was discussed threadbare when we started this policy. And as Dr. Sheth was telling, we are attempting to integrate the various services, and the district hospitals will be under the mentorship of a medical college, and a faculty from the medical college in that specialty will be assigned for the mentorship of these candidates. So it will be under the supervision and tutelage of a medical college in the vicinity in which that district is located. So it will be a win-win situation, and there is a full possibility of the tutelage teachers to allow the district hospital postgraduates to come to the main hospital, see some bigger cases also, and likewise there a lot of exchange program and friendship and things will start once the whole interaction comes in. And I think this is a game-changing policy as far as the quality of care is concerned for delivery to the people, but also to the trainees, because the specialists in the hospitals are doing very high quality volume and very high quality work also. They do limited amount of work. They may, in our specialty in surgery, he may not be doing 25, 30 operations. He may be doing 10, 50, 12 common operations, but doing them very well, without any help, without any resident. And now in such a system, when residents come in, you can imagine the kind of fillip that the whole training will get. So we are very excited about it, but we keep our fingers crossed. We will keep a very strong vigil on it. We will have to monitor it very carefully. And that is why some more diplomas which were envisaged to be added to these 8 have not yet been added, so that we could get the confidence of the rollout of the first 8 diplomas, and then a few more courses could also be added in the subsequent years.
Okay, thank you. Dr. Kanagwel, you have so many questions.
Yes, sir. I think most of the questions are getting answered by and large. But this question will be next to Dr. Abhijit, sir. Sir, I am going to address 2 things together to you. Number 1, there have been always some subtle difference between the way the exams are done by the NMC, exams are done by the National Board. National Board always takes leverage, or they are always more futuristic, and they are quite early to implement the potential specialties, subspecialties, and micro-specialties. Taking that into consideration, in fact, National Board utilizes more of the medical college examiners. National Board utilizes more of the medical college-based teachers also towards various exam part of the National Board exams. But the students, many of the questions, sir, why is that there is a difference of name to the degree offered by the National Medical Board, National Board of Examination and the National Medical Commission? Say, can it be redesignated as MS National Board or MD National Board? Together, if MCI gives, it becomes MS, and if National Board gives, can it be MS National Board or MD National Board? And then they also would like to know, sir, still few of the F&B programs and few of the super specialized diplomas program of the National Board are not registerable in various state medical registries, medical councils. Can you please highlight upon these differences, and what are the reforms which are planned in future, sir? Sir, please unmute yourself.
Yeah, first of all, sir, now National Medical Commission, everyone must accept that it has a direct obligation with the Parliamentary Act of Medical Act. And it's not easy for them to amend it or customize it to the general needs. I think whatever they do, they still abide to the National Medical Act. It is modified, but still it has certain level of restrictions on the way it advances further. In National Board of Examinations has a lot of leverage because we are not regulating agencies like NMC. So certainly we have a lot of leverage, as you rightly said, to start new courses, new subspecialties, and everything. It's much uh, possibly, I would say, we are bit liberal for it, to save it. Now, then comes the uh, equivalence issue. Now, equivalence issue has been largely addressed by erstwhile MCI, BOG, and equivalence has already been brought into the broader specialty to a larger extent. Now it's up to the state medical councils or state medical education body to ensure that this equivalence is applied into the employment and into the job opportunities. So that has been done already. There's no need to change. The reason why you don't need to change is they both are different system to an extent. Their curriculum and our curriculum, the principles are same, but the way it is handled it's a bit in a different way. So I don't think so that we can match it in an absolutely equivalent way by all the aspects. But having said that, all efforts has been done to ensure that the broader specialty DNBs will be equivalent to the MDMS program. So with very little now regulatory mechanism for it. So that part has been addressed. Now coming to the FND, I have already said that these programs are largely to enhance the skill of already existing postdoctoral courses. So there's no question of recognition for these courses as such at this stage. The recognition comes to the issue where the super specialists are made, like DNB cardiothoracic surgery or DNB in other super specialist course, because there where the original educational requirement of the National Medical Council through the Medical Act has been implied, while this has not been implied into the fellowship courses. Second, about the diploma courses, I don't think so diploma courses will be recognized by the NMC at this stage. Diploma courses, I'll tell you why. The reason is simple, that diploma courses, again, the basic principle and objective of starting the diploma courses is to ensure that our undergraduate students, maximum number of undergraduate students should have an access to a specialist training, and they can go to the farthest part of the regional medical institution to serve the country. So that is the main objective. The main objective here is to not to create a huge number of specialist cadre into one branch or one area. Otherwise, people will go out of the job. So principle is simple, that there is a very clear objective defined for starting the diploma courses. So that is why diploma courses will not get an equivalence, but the students who will eventually transit from diploma to the degree courses, then they will be recognized once they will get a degree. So at the moment, the simple summary is DNB is made equivalent with certain conditions, but the conditions are not as harsh as it used to be before. Number one. Number two is FNB and diploma is not recognized, and it is unlikely to be recognized by the NMC. That is very clear. And number three is, as far as the job equivalence is concerned, it is up to the state state health department to ensure that they respect the equivalence in employability of these doctors. So that will conclude this question.
Thank you, sir. Dr. Lal, you want to add something? Yes, sir. So please unmute yourself. Yes, sir.
Yeah, I just wanted to supplement what Dr. Sheth said, that in the NMC Act now, in the act which with which the NMC has come into being, in the addendum to section 37, a schedule has been added, and all the degrees which are awarded by the National Board of Examinations are recognized registrable degrees, and there should be no problem for any commission in the state commission to object to that. So if there is anyone happening like that, it is going to be violative of the new NMC Act, and I'm sure good sense will prevail on authorities, and they will grant the equivalence or recognition to the specialities that you were asking. So that's just to close that question.
It's loud and clear, sir. Thank you. Thank you. Dr. Aman, sir.
So, Dr. Lal, coming to some very specific questions, one of the things that we are realizing in a hurry to increase the number of specialists or number of PG students, we are overlooking the number of faculty available or infrastructure available. So if we had one faculty and there were n number of PGs, now the PGs have been increased, but the operation theaters are not available. The operation theater timings are not available. So if a PG would do, let's say, just for the same example, 10 appendix in 3 months, now he probably gets only 1 appendix because there are too many candidates for the same appendix. So how are you going to answer that? Is that not a worry that this will compromise the quality of training of our PGs?
I think that's a very, very important point which you have brought out, Dr. Goel. And this concern is actively addressed in the National Board when we evaluate the infrastructure of any hospital at the time of accreditation. We look at the numbers that are being done, and we are not, we are very, very careful in allotting the number of seats. However, the same cannot be said for the medical colleges, where I have, as a part of the medical college I have been from, the number of seats have got doubled up, senior residents have got doubled up, faculty members have increased, but the infrastructure has not increased to commensurate with that level. And I think that challenge is to be met, I would say, by both the hospitals and the stakeholders and the government. It would not be right for us or for anyone to simply blame the government for being, being responsible for doing that. I think equal responsibility remains with the with the stakeholders who are there. The departments who are there, the medical superintendents who are running the hospital, the deans and principals who are running the college. There is never ever a dearth of money in the government system, but for some reason there is a myopic view, and people are not wanting to see this as a very important concern, or they don't want to take too much in their hands, because when they ask for too many things, then they have to be given to be responsible for all those things. So I would say that this has been a little bit of a setback from the stakeholders end rather than the government end. As far as the government is concerned, wherever I have seen, when we go and want something, they are pretty liberal about it. It is only our own fraternity and our own people in the administration who are not able to show that much amount of liberal view and a more longevity view, that the hospital or the college has to run for 15, 20, 30 years from now. So they need to be more vigilant from that point of view, and I think that concern is something that then comes on the quality of training, as you very rightly said. And this is a bit of a catch-22 situation, and I would also say it is also sometimes the fault of the students also, because they also accept the situation as it is. I was at one point of time, I can just say informally now, that I went for an inspection of a medical college and for an exam in a medical college, and I found that there were 16 postgraduates there, and there were only 2 faculty members. It was a medical college. It is about 10 years back. And then I asked how you are coping. He says, we are just coping. And they said, why are you coping like that? He says, if we complain, then we will be losing our MD, MS seats. So the students are not complaining for that reason. And, the whole system is just continuing. And of course, that point got highlighted, and then more faculty were given, and the training got eventually sorted out. But it is sometimes the lackadaisical attitude from both the ends of the stakeholders, and the time-consuming reforms. And the other thing that I found is that people at the administration, they are now getting made from seniority in government circuit rather than longevity of exercise. So when they are at retirement for 6 months, they are becoming dean of a college or a medical superintendent. They don't have a span in front of them. If they don't have a span in front of them, they will not be able to execute those changes. If people are just made for seniority, they are only there for 5-6 months. Either he will just pack his bags, or he will do something new, because they cannot start anything new which another person is likely to follow or not. So those are some of the challenges, and government is quite aware about it. But I'm sure a lot of thought process is required to basically sort this out, and I'm sure it will over a period of time.
Okay. Dr. Kanagvel, you have any question?
Yes, sir.
Yeah.
I will ask a quick question to Dr. Abhijat, sir. Sir, so far, whatever we have been deliberating has been in the early part of the learning process of a doctor. So we talked about the undergraduate, we talked about the postgraduate, we talked about various regulatory issues. But sir, being a thoracic surgeon yourself, you have spent enough time upgrading your skills after your MCH qualification. Somehow or other, the regulatory bodies get them educated, give them degrees, and beyond 35 or so, they are left to learn by themselves. But then somebody's skill gets refined after they get qualified. All of us are evident. Yes, effort well spent on one single surgery or one single subspecialty for 10 years or 5 years obviously give results. But somehow or other, we do not have a skill assessment system or skill imparting system. Somehow these people who have finished their MCH or DM or DNB in specialization are left apart from themselves to fend themselves. And we don't have a standardization, or at this point, we don't have a level playing platform for them to upgrade their skills. What is the national board or what is the government at this point or looking at the mid-career level skill upgradation, sir?
Two, three things, which is even the NMC, MCI has taken initiatives, and we are also going to take these initiatives. It is interesting that even in our accreditation process, the skill lab was one of the important criteria for each and every institution. But I can tell you, sir, that 80% of institution or more doesn't have these facilities. And since the complexities, advancing technology, and all these things has increased, now this is a very different situation. In public sector, you have a patient load. In private sector, you have a best quality equipments and experts to run the equipments. So naturally, otherwise they won't put an investment to the equipments. So this is where you can develop a lot of skill sort of training. The problem is, as I said, that when this access will become more free to the students, that students where they need sort of exposure to the caseload, and they can be rotated to the public sector, and the students who needs an additional training for the skill-based or equipment-based training, then they should be rotated to the private sector. Let us take it in your gastroenterology that the laparoscopic surgeons. Now, if you need to develop minimal access or laparoscopy, you have specific centers for it. If the DRB students is given an access to these institutions, then possibly they will be able to build it up. Now, what is happening there? I must accept that current resources for the skill trainings is not adequate, and that is why we are suffering. But the way in which the aggressive manner, both the government of India as well as the regulatory body NMC and ourselves are taking the policy decisions is to ensure that in coming few years there will be a almost equivalent time of that's why I mentioned about 3 arms, 3 pillars. Currently it's not a pillar at all, but that's why I said that the skill-based training will become an essential pillar in the training of DNB, and the resources will be created, available and accessible to the students. So these resources initially will be created by the national board on the central level, and like spokes of the wheel, eventually we will encourage the private sector institutions or even the governmental institution, whoever resources, to make this as a center of training and learning for the skill centers for the students. So certainly this is the much needed reform of the hour, and now it will not be on the papers and it will be certainly implemented, and the access to the students will be increased to the best of its ability in coming years. That I can assure.
Thank you, sir.
Dr. Sheth and Dr. Lal, we thought that we'll finish it in 1 hour, and we have at least 30, 40 or more questions still waiting, which the participants have sent. And so what we will do now onwards is we will have a rapid fire round, which we hope to have elicit a specific response, a brief response from you, so that we can finish it in next 15, 20 minutes. Otherwise, this will go on. And before Dr. Kanagvel starts having that rapid fire round at you, I just wanted to make an observation. It seems that first time the policymakers are thinking of postgraduates as a service provider when you are posting them in district hospitals. More than the training that they are getting, they are going providing a service to the citizen. And then the question arises, why should postgraduates be asked to do a bond after their post-graduation anymore? And why should students be charged for post-graduation by their respective medical colleges? Because I don't see this happening in United Kingdom. We are, in a way, replicating the NHS system by using our postgraduates to provide health care. As you said, this is an integration which is happening. So I am just leaving it as a thought, because this is something which will require a major change in policy, and there are private medical colleges and other issues. But I think this is very unfair that when we are using our postgraduates, and this is only in medical side that they are asked to do a service bond, a rural service bond. It is not engineering, it's not in MBAs. So I think since both of you are at the helm of affairs, and you have the ear of the health minister and the prime minister as well, I hope that in future we see some movement on this, because parents like us, your children also have studied in medicine and know how much they need to spend, and then the sword of rural posting remains on their head. So Dr. Kanagvel, I'm not asking for a response from them because this is a major policy issue. Please go ahead and you can ask alternate questions from Dr. Sheth and Dr. Lal about the specific issues. Yeah.
Yes, and maybe I can be very pointed questions and a curt answer so that we can take more questions and cover up most of the important issues have been covered, and few of the pertinent issues I'm going to touch upon. Dr. Lal sir, there have been a lot of questions about the exam dates. Can you briefly give an announcement on the NEET exams which are going to come up, the time schedule for the theory exams and practical exams which are on the annual? And there have been also one question, will time spent on treatment of COVID be taken as loss of training period, whether I'll be given extension? These are the quick things. Based on the time frame, you can quickly answer, then I move on to Dr. Abhijit.
Right. So I think the NEET exam is going to be announced very soon. We are just waiting the nod from the Government of India to give you the date, and it should happen sometime in April or May. So let them be ready that it could happen either of the 2 months. As far as the DNB exams are concerned, those who have done the theory exams in September, which was the June 2020 session, most of the results have been declared now this month, and they will be all ready to take the exam in the month of March and April. So the practical exams will start in March and April. And in the same month, March and April, the theory exams for the new batch will also take place. So that is the time schedule for the, the exams. And what was the last bit about it?
The PDCET exams.
Yeah, the post-diploma common entrance test is always held about 2 to 3 weeks after the NEET PG exam. So as soon as the NEET PG exam is announced, the post-diploma CET will follow about 2 to 3 weeks after that date. So it's something in April and May is something they can hope for. As far as the COVID period is concerned, all the trainees who have done their training in the national board during this period and finishing their training in year 21, the training has been extended for a period of 3 months in view of the COVID situation. And it may increase further in line with the National Medical Commission if they extended more than that. But as far as all the NBE training institutions are concerned, it will be extended and it will be notified shortly.
Thank you, sir. Dr. Abhijit, sir, there has been a question on how the faculty is going to be trained in district hospitals. You have been talking about utilization of the district hospitals, and the MCA mandates a professor to have 8 years and so many publication, associate professor to have so many years of experience. You want to take that question, sir? Let me finish. So how, and don't you think a student getting trained in a structured faculty program, a professor has come, and a professor, a consultant or a non-teaching professor who is going to train the students in the district level hospitals, how does this difference being addressed by the board or the NMC, sir?
So as far as the board is concerned, as Dr. Seth had pointed out, we do not like to differentiate as far as the teaching is concerned between the separate silos of private and government. And most of our trainings are already taking place in the private sector hospitals, and there are no professors there, but they're very high quality teachers and specialists who are excellent in their own specialities. So likewise, the district hospitals where the diploma courses will start, they will be having their full degree qualification, and it is mandated that where there is a teacher who is more than 5 years post PG will be recognized as a teacher for the diploma, and in the absence of a senior faculty, 2 junior who are 2 years post qualification will be required. So most of the places 2 juniors are never there. It's usually the senior who is there in most of the situations. So 5 year or more, and normally speaking, most of the people there are several years, 8, 10, 20 years experience there. So we don't think that there should be any compromise on the teaching. The curriculum is very well structured for all these diploma programs and even our other degree programs. And we actively engage with all our specialty boards to revise it from time to time as the situations have been, as the program or the curriculum changes with advancement, so that the curriculum is up to date with the recent advances incorporated into it.
Thank you, sir. Now I move to Dr. Abhijit sir. Sir, there have been questions about age limits of the faculty. The National Board and the NMC are what is the stand which is being taken on the upper age limit of teaching faculty? Is there any proposal to increase that, number one? And few states have 58 as retirement. The central institutes have 60 or 65 as a retirement. What is the as a like I would say implementing body of the government? What is your take on the upper age limit of the faculty, sir?
Sir, in National Board, we have already increased the faculty age to 75. And after 75 years also, we have an academic committee which will take a call to continue for a couple of years more, but certainly not beyond, I think not beyond 80 at any cost at this time. Regarding the NMC, it has been increased to a certain level, and they are taking an advantage of retired teachers from Army and other to be working as a faculty. But I'm not aware with the exact age limit for them. But for National Board, we are clear that up to 75 we have increased.
It's up to 70, sir. For the National Medical Commission, all medical colleges is up to 70 years, and we have it at 75 years.
Thank you, sir. The next question is quite contentious, but then I would like to put this question to Dr. Lal. Sir, the number of chances, especially in very fine procedures like liver transplantation or high-level interventional cardiology procedures or like interventional valve replacement to quote, I think many questions I'm clubbing together. In corporate hospitals where F&B programs or DNB super specialty programs are done, or many times are very micro specialized, and even consultants get to do very minimal procedures. And on the bargain, a resident or a super specialty resident is not getting adequate hands-on. What is that the board is envisaging to streamline these type of high-end specialties where consultants get to do most of the procedures and we end up assisting all through?
Right. So I think this is something that we have actively engaged with all the specialty boards of these concerned specialties, and it is not restricted to just super specialties. In any kind of training, there has to be a basic minimum number which must be fulfilled or satisfied. And I think once the logbook comes in, it will become a very important source material, because it will be on record what is the number which has been performed independently, what has been done with assistance, and one which is done without assistance and with supervision. So I think these are important issues, and we tend to look at it and review them periodically with the specialty board members. And we are specific that for the fellowship programs, we would give it to only those centers where there are very high volume and ready to pass it on to the trainee, because the fellowship programs are mimicking the United States fellowship model, where the candidate once comes out from a fellowship program should be able to be recognized as a good quality trained person in that particular super specialty or whatever it is, where either a medical or a surgical field.
Thank you, sir. Thank you. Sir, one question to Dr. Abhijat. Very specific question, I say. I think there have been some select centers where, as Dr. Lal sir was telling, continuously being gauged and monitored. If they are not able to maintain the quality and the number of cases, students are getting shifted to the next possible center. The few students have asked, sir, does it mean we have to undergo the remaining period alone, or we have to finish the mandatory period? Lal sir, please, maybe.
Yeah, so you see, this is maybe a matter related to relocation, and the relocation is a very unpleasant task which we do not encourage at all. However, there are circumstances where we have no other way but to be forced to do it. For example, a hospital closes, some of the financial situations of the COVID, led to that event. And also at some places where the candidates were not very happy with the way the institution was treating them, or for whatever reasons. So when the relocation takes place, it is very clear it is only for the remaining period of the training, and the whole of the period is never repeated. And normally we would shift the first year only, the candidate who is the first year entrant, because the second year is already undergoing a thesis project, and the third year person is already coming to the end of the training. So we would not like to touch these second and third year. But there are some institutions where we are forced to do it because the institution is getting closed, or the situation is bad between the student and the institution, and there is a request to do so either from the institution or from the student, and there are all other avenues are closed. Only then we try to do for the second and third year. Otherwise, the principle is for the first year.
One last adding question, sir, before I hand over to Dr. Aman Goel, sir. So the National Board has been very clear and categorical about the maternity leaves and the total number of holidays where a student is eligible per year and over a period of the entire training phase. Is there any ultimatum which is given on the number of hours per day a candidate, I would say the maximum number of hours a candidate to be spent, or the time working hours per week? Do we have any regulations on that, sir? Yes, sir, please.
Yeah, so I think no, we do not have any working hour system as of now. We don't have any European working time directive working in India. So we do not encourage that. We do not want to say that training is a continuous process, and the word resident means that you are resident in the hospital. So that is the whole ethos of training, and it's a residency based training. And the more they are there in the hospital, within the patients, within the training system, the more they will learn. So we at the board do not have any policy for that. However, the leaves are, as you said, very clear. 30 days per year is allowed. So total of 90 days is something that is permissible. And if there is any extension beyond this number, then the person has to be undergoing that training beyond that. And if sometimes the training does not finish before a cutoff date, then the candidate is not allowed to appear in that exam. And if somehow a candidate has willfully or otherwise hidden that information from us, appeared in the examination, and at the final stage it is brought to our notice that the person actually had not completed the training, the results of that exam are declared null and void, and the candidate has to go for the theory and the practical exam all over again.
Thank you, sir. And now I hand over the proceedings to Dr. Aman Goel, sir. Over to you, sir, please.
Okay. So I think we have already extended the time quite a bit. I see that both of them are now looking at the clock. But I have two important issues. I won't let you go away because they have been asked by almost everybody. So the first one is to Dr. Lal and the last one goes to Dr. Sheth. Dr. Lal, the problem is that our post-MBBS doctors are all busy preparing for exam, the PG entrance exam for years together. And that compromises the quality of care in hospitals where they are working as RMOs or doctors. I'm aware that the government is planning to do an exit exam. But exit exam, in addition to the final year exam, is basically overlap. So can you clarify what exit exam stands for and how it will be held?
Sir, thank you for this question. Actually, the exact clarity on this would be brought in by the National Medical Commission. They have just been formed, and the undergraduate and postgraduate boards are yet to meet. The mandate by law is that they are supposed to do the exam, the next exam, before 2023. That means before 3 years of the promulgation of the Act. So since the Act has now come in through and the Commission is completely in position, it will be somehow in 22 or 23 that the next will come in. And the exact structure of the exam is not yet known even to us. But what I understand is that this will be a single exam. There will be no two exams for the final year. So it will be the passing exam for the final MBBS. It will also be the ranking exam for the PG entrance, and it will also be the licentiate exam to practice in the country, thereby giving way to the FMG exam. The FMG exam will no more be there.
Okay, thank you. So I think that was essential to have a clarity on this. And now, Dr. Sheth, a very contentious issue. All the doctors are very agitated. Indian Medical Association has taken a very tough stand. You know what I'm talking about. IAGES has also clarified its stand to stay with IMA. What is you are a surgeon yourself. I'm not asking what government is thinking or what Ayush Ministry is thinking. I'm just asking you as a surgical colleague, not as a government functionary. What is your opinion on this Ayush doctors being allowed to start surgery or allowed to do surgeries on a wide spectrum of things, right from laparotomy and minimal access surgery for gallbladders and all, without having adequate training or without having an infrastructure?
See, the one thing I will tell that the Ayurveda, the Shalya procedures and that I'm not very deeply aware with it. So they justify based on the Shalya procedure, and that's what they are doing it. But my submission is simple, that allopathic procedure has its own science and it goes in its own way and own protocols and procedures. And certainly in whatever Shalya procedures they are doing, but it should not be mixed up with the allopathy. So I think it's very clear, because this will cause a lot of confusion. The main feature of this confusion will be particularly when the student comes out of the after passing the degree and everything, and they want to aspire their career into sort of different countries or anywhere or other places. Certainly this will create a lot of problem. And my submission is very simple. I'm not here going to criticize directly on the Shalya procedure issues, but I'm one thing which I always support, that allopathy should remain allopathy, and it should not be mixed with the other sciences.
Thank you. So friends, this is what I meant when we started talking today, that we have two surgeons who are leading the board, and the surgeons have a different way of looking at things. The clarity of thought, they answered all the difficult questions with so much at ease that it makes us realize that the country is in safe hands, and the National Board of Examination will, whatever within their power, will move ahead with guiding the medical education in a proper way. So thank you so much to both of you. May I request the Honorary Secretary of IAGES, Dr. S. Ishwarmurthy, to please propose a vote of thanks to both of our guests.
Thank you. Thank you, Dr. Kanagavel. Thank you, Mr. President, Dr. Raman Goyal, for choreographing and presenting in yet another blockbuster IAGES Prime Time today. And I'm sure all our viewers would agree it has been a pack-filled, absorbing day for all the academicians across our country, because so many information have been shared by both the great personalities here, Dr. Sheth, the President, and also Dr. Pavanendra Lal. I really like your attire also. Looking at the temperature in Delhi, I really admire your attire. My personal greetings to you. And thanks for both of your valuable time and input. And I'm sure, you all agree. Another point I would just want to share with the role. Like, for example, other countries, like Dr. Sheth Lal also trained 10 years in UK. We know the system, how they work in UK and also US. In American Board of Surgery, as you know, they have accepted some of the training by SAGES, like FACE program, as one of the prerequisite for the people to board certified. Same thing like in MRCS, some of the basics some skill course from the Royal College, they take it into account. So like that same ground, because we all like academicians, we may be in a surgical society, IAGES, you all know we do on-site and online academic programs and a lot of skill courses. We can share your responsibility. And if you could take our 3-day certificate and fellowship courses as part of the requisite, if you could pass a message to all your postgraduates if they come and attend, because that will intensify if they come. For example, you run year 2 postgraduates and come the certificate course of the basic the laparoscopy endoscopy skill course, and all the dip-and-B super specialty, they can come as a false course where advanced or a 5G course. Like that we can do that. That's my just a thought. I was listening to you, fascinated by all your inputs. So this is another spectrum we could think, win-win situation, not specifically to IAGES. All the society, medical and surgical societies are doing a phenomenal work. I'm sure collectively we can take our country even to a greater heights, because we know all of us, India now high up in the ladder as far as the academic and also the medical tourism is concerned. I think it is our own responsibility to do in that way. And there are a couple of things in the same tone. All of you know that we as an IAGES, we have been initiated by, thanks to our president, an academic initiative of the best PG thesis award. I mean, this year actually we have shortlisted 10 postgraduates out of the applications we had. 5 of them is going to get 1 lakh rupee as a best research. So both dip-and-B and also MS. So we are going to have the interview. I want to see all the postgraduates listening to you. So next, it is going to be our Pongal Prasan. We say in Tamil Nadu, we are going to celebrate the harvest festival. So it's something like that. I'm very, very proud to announce that. And also in the same way, we are going to have our online fellowship examinations are going. So there are 300 people who are benefited by our, in spite of the COVID pandemic, we conducted the FAGS, EFAGS, false courses, wherein they are going to have their online MCQ and also the online assessment Viva. The same way the dip-and-B conducted, I have watched how they did it. So we are going to take a lot of inputs from the way you conducted, the way other countries. So we are going to learn a lot from you. So it's a win-win situation for both of our associations. So thank you all. And I'm sure all the fellows, once they qualify there, they'll come to our IAGES 18th conference and convocation in Coimbatore. And you'll be there in a colorful convocation with us on 9th May. Watch your date. It is because I'm sure 16th is a big day for India. We are all having the vaccine drive. So I'm sure by May, most of us, all the medical fraternity will be ready to go and mix with your friends and family. So welcome to Coimbatore. And I'm sure we have had a great day thanks to Docplexus. Again, I'm sure with the postgraduates now watching, I saw the YouTube also, a lot of kids there. So thousands of people watched, got all the inputs from both the great personalities. Thank you once again. And thank you, Docplexus. Thank you, President, for bringing yet another blockbuster. Thank you. Good night.
And
Jai Hind.
Thank you, Ishwar sir. I take the privilege of announcing the next prime time information. We have Professor Paul Sugarbacker accepting to be the next important faculty. I'm sure all of the surgeons would know the work done by Professor Sugarbacker on surface malignancies and cytoreductive procedures. So that will be in the last Sunday of IAGES Prime Time. And we have eminent society presidents of across the globe piped up on. We'll be announcing shortly. So we are trying to improve the bar of IAGES Prime Time by the day and by the event. We look forward for more academic collaborations. And I thank the president and the secretary for allowing me to do this program. And I also thank the invited faculty, Professor Lal sir and Professor Abjad sir, for making this day a very lively one. And I'm sure a lot of more than 3,000 people have come in. And I'm sure this will be watched across the platform as we have in the IAGES channel and the Docplexus channel available for a longer time. So I'm sure it will reach more hands. Thank you one and all. Thank you IAGES. And I thank all the participants in various channels, both in Docplexus, IAGES, and in Facebook Live for joining us this evening and making this evening a more successful one. Thank you one and all.
Thank you.
Thank you.
Thank you.
Good night.